Next is eye optical trial and eye opener by Dr. Rony Mathew. Actually, he is pioneering work in OCT in India, similar to Light Lab work what Kevin and others did there. Similar studies done in India, highlighting some of the important aspects how the OCT changes its decisions. And let us hear more about it from Dr. Rony Mathew. Thank you, Rony, for again sparing your time and participating in this. Over to you.
Thank you, Dr. Srinivas. I hope you can see my slides and hear me too.
Yes, yes.
Great. It's a pleasure to be here at TCT, especially in the company of greats, Dr. Gary Mintz, Dr. Ziad, Dr. Ashok Seth, and Dr. Kevin Kroc. Hi, Dr. Kevin. So I'm going to present to you the IOPTICO study, and the study was done in the Indian subcontinent. And I don't have a disclosure, though it's an investigator-initiated study. It was supported by Abbott Vascular. So the study objective of IOPTICO was to assess the impact of real-time OCT and angio co-registration on physician decision-making for PCI optimization in South Asia. And we had 9 sites from all over the country. We had Dr. Tejas Patel from Ahmedabad, Dr. Hiramat from Pune, Dr. Samuel Mathew from Mumbai, Dr. Balbir Singh from Delhi, Dr. Shengetwelu from Chennai, Dr. Vivek Kumar from Delhi, Professor Fazila from Dhaka, and Dr. Shivakumar from Madurai. Our co-lab was at Chennai at the Madras Medical Mission, and Dr. Vijay Kumar did a wonderful job. So as I said, the primary objective of this study was to assess whether OCT imaging after angiography altered our PCI procedure when performed pre or post PCI. Pre-PCI strategy, the points noted were whether there was a further need for lesion preparation, whether there was a change in the intended stent length and diameter, and whether there was a change in the stenting strategy. Post-PCI OCT optimization involved identification of stent malapposition, dissections, under expansion, plaque prolapse, or an incomplete lesion coverage. The secondary objectives were the angiographic procedural success, the MACE at 6 years and 1 year, and the cath lab metrics. What I'm going to present today is the interim data that was presented last year at the TCT. Now, I'm very happy to tell you that we have completed the 6 months and the 1 year follow-up. The MACE and this data is at least been submitted to the TCT this year, but that will not be part of this presentation today. Now, we have a very unique study flow, and it was real time. Now, each investigator had an assistant who would enter data real time as the procedure progressed. So prior to the procedure, based on the angiogram, the operator was asked to define the procedural strategy based on the variables I just discussed with you. Whether there was a need for further lesion preparation, what was the intended stent length, diameter, and the landing zones were marked on the angio and the stenting strategy determined. Now, subsequently, they performed the OCT. And based on this additional information provided by the OCT, the changes in strategy were documented real time by the investigator. At this point, the angio co-registration was applied, and any further changes in landing zones or any other study variable that I discussed was further documented. Now, based on all this information that the investigator got, he performed the PCI. And post-PCI, the OCT was done to determine whether further optimization was required as far as malapposition, expansion, under expansion, etc. And then again, the ACR was applied, and it was documented whether a strategy change was required. Now, everything was analyzed at the co-lab. Now, we enrolled 500 patients between November 2018 and March 2020 from 9 sites across India and Bangladesh. We had to exclude 28 patients from the primary endpoint analysis due to inadequate imaging. So 472 patients were included in the analysis. 2 patients died after 3.5 months of the procedure. So at follow-up, we had actually, this is what was presented last year, but right now we have the entire 472 patients who have been followed up at 6 months and 1 year. Now, if you look at the baseline characteristics, it's more or less what we see in some of these busy labs in our country. diabetes in about 50%, hypertension in about 57%. And if you look at the indications for PCI, about 80% were ACS. And the lesion characteristics, not surprisingly, some form of calcification was seen in about half the patients, and type B and C was in the majority. And that's again a snapshot of the type of patients we see in our labs in this part of the subcontinent. Now, coming to the results, if you look at the left panel, there was a change in the PCI procedural strategy once OCT was performed after angiography in about 76% patients. And this included a further need of lesion prep in 25%, change in stent length in 53%, change in stent diameter in 36%, stenting strategy in 4%, and change in the landing zones in 61%. Now, once OCT was performed, adding angio co-registration further changed our PCI decision strategy in 22%. And that was predominantly due to change in the landing zone, due to which we had a further lesion preparation in 15%, change in stent length in 10%, and a change in the stent diameter in 5% of patients. Post-PCI, OCT identified a problem that required additional intervention in nearly 30%. And this included underexpansion in 15%, malapposition in 15%, edge dissection in 3%, and a tissue prolapse in 7% of patients. Not surprisingly, adding ACR at this point did not have any additional strategy change post-PCI. The secondary endpoints, running through this, the average time required for conducting the OCT pre-procedure was around 6.6 minutes and post-procedure 10.7 minutes. The contrast used was 205 ml. Additional contrast for OCT was 40 ml. Now, so if you look at the overall impact of the iOptico, what it showed was the overall impact of OCT and ACR during PCI. Pre-procedural OCT changed decision-making in 86% of patients, and overall post-procedure in 30%. And if you look at OCT plus ACR, it changed angiographic-based decision in nearly 90% of our lesions in this part of the subcontinent. So to conclude, this was the first South Asian study reporting the outcomes of OCT and ACR-guided PCI in this part of the world. And OCT and ACR changed our angiographic-based decision in 90% of lesions. Pre-procedure OCT changed strategy in 76%. ACR additionally changed strategy in 22% lesions. And post-procedure, the OCT showed a further need for optimization in 30% of lesions. I would present the one-year clinical follow-up data at a later date. So before I say thank you to you all, I never knew about Dr. Kevin Kroc and the Light Lab study, but once I got to know that these were two studies that were done in two different parts of the world with two sets of investigators who never had a contact. Of course, I know him now, but I didn't know him at that point of time. And if you look at both these studies, more or less showed that imaging helps you to change decision making. And importantly, the majority of the change in decision making is in a pre-PCI OCT and not a post-PCI OCT. Thank you all for your kind attention, and I thank my co-investigators for helping us out. Thank you.
Thank you, Dr. Rony. Actually, that is the power of truth. If you are truthful and do what is right, it will come the same whichever part of the world you do it. Thanks, sir. Thanks for it.